Orthodontics. Masterclass. The science of timing and growth. Good morning, everyone. Today we are not here to talk about brackets, or about wires, or even about aligners. Today we are here to talk about time. If you think about it, orthodontics is essentially applied biology. Mechanics alone cannot explain why some treatments succeed and why others fail. We know the equations of force, we know the calculations of torque, but the real secret is this: biology has a clock. Growth happens in windows. Bone changes only when biology allows. If we respect this clock, we succeed. If we fight it, we struggle. Imagine this. Two patients come to you with the exact same diagnosis. Both have a Class 2 malocclusion. One is 11 years old and just entering the pubertal growth spurt. The other is 19 years old, with growth already complete. On paper, the malocclusions are the same, but clinically, they are completely different. The 11-year-old can be treated with growth modification. The 19-year-old requires camouflage or surgery. That is why treatment timing is not a minor detail. It is the very foundation of modern orthodontics. By the end of this masterclass, you should see orthodontics as more than tooth movement. You should see it as growth management, face design, and the art of working with time itself. Let us begin with the foundations. Section 1. Biomechanics meets biology. When we move a tooth, what are we really doing? We are not simply pushing enamel through bone. We are manipulating a living system. That system includes enamel, dentin, cementum, the periodontal ligament, alveolar bone, blood vessels, nerves, and cellular responses. When we apply a force to a crown, it is transmitted down the root. The periodontal ligament compresses on one side and stretches on the other. On the pressure side, osteoclasts resorb bone. On the tension side, osteoblasts deposit bone. If the force is light and continuous, the periodontal ligament remains healthy, and bone remodeling occurs steadily. If the force is heavy and intermittent, the blood vessels are crushed, the ligament undergoes hyalinization, and root resorption becomes likely. Here is an analogy. Think of the tooth as a tree planted in soil. If you push gently, the roots shift and the soil adapts. If you push violently, the roots may fracture and the soil cracks. Now add the dimension of age. In a 10-year-old child, the alveolar bone is pliable, marrow spaces are wide, and sutures are open. Orthodontic movement is fast and cooperative. In a 25-year-old adult, the alveolar bone is dense, cortical plates are thick, marrow spaces are reduced. The same force moves teeth much more slowly and risks damage. Clinical pearl: never treat a 10-year-old child with the same mechanics you would use for a 25-year-old adult, and never treat a 25-year-old adult as if they were a 10-year-old child. This is the first lesson in orthodontics as applied biology. Mechanics may be universal, but biology is patient-specific, and timing decides biology. Section 2. Tooth size and arch size discrepancy. One of the earliest diagnostic puzzles we face is what to do when there are too many teeth and too little arch space. Option 1. Space maintenance. When a deciduous tooth is lost prematurely, adjacent teeth drift into the space. The result is arch collapse and future crowding. With a simple appliance such as a band and loop or a lingual holding arch, we can preserve the space until the permanent tooth erupts. Clinical pearl: preventive orthodontics is invisible success. No parrot will ever thank you for preventing crowding that never happened, but prevention is the highest form of success. Option 2. Serial extraction. When the discrepancy is severe, often 8 to 10 millimeters, planned removal of teeth may be necessary. This involves sequential removal of deciduous canines, then deciduous molars, and eventually premolars. The goal is to allow the permanent incisors and canines to erupt into better alignment. Analogy: think of urban planning. If a city has too many buildings and too few roads, sometimes you must demolish strategically before rebuilding. Option 3. Expansion. Expansion may be slow or rapid. In patients younger than 12, skeletal effect is possible because the mid-palatal suture is still pliable. In patients after puberty, resistance increases, and most of the expansion is dental tipping, not true skeletal change. Pearl: Expansion after the growth spurt is like bending steel instead of bending wood. Both can bend, but the stress and relapse risks are much higher. Case correlation. A 9-year-old girl with 8 millimeters of crowding. Serial extraction was chosen. The permanent incisors erupted straight with minimal appliance wear. A 14-year-old boy with the same 8 millimeters of crowding. Extraction would have flattened his lips and aged his profile. Expansion and interproximal reduction were chosen instead, preserving the profile and improving function. Lesson. The same diagnosis handled differently depending on timing. Biology and age change the tool. Section 3. Class 2. Malocclusion. Class 2 malocclusion is one of the most common challenges we face. It is also the clearest example of timing. In children, mandibular retrusion is often the underlying cause. Functional appliances such as the twin block, the Herbst appliance, or the mandibular anterior repositioning appliance can harness growth to advance the mandible. But they are not magic. They only work if growth is available. The golden window is the pubertal growth spurt, specifically cervical vertebral maturation stage 3. In adults, the same appliance does not grow the mandible forward. All you achieve are dento-alveolar compensations. At that stage, camouflage with extractions or surgery is required. Case correlation. A 12-year-old boy with a retrusive mandible and convex profile. Treated with Herbst appliance at cervical vertebral maturation stage 3. Mandible advanced, profile balanced, occlusion corrected. A 19-year-old with the exact same cephalometric analysis. Herbst appliance attempted. Only tipping occurred. Surgery required. Analogy. Class 2. Treatment is like catching a train. If you arrive at the station during the growth spurt, you ride the train. If you arrive late, the train is gone and you must walk. Section 4. Class 3. Malocclusion. Class 3 malocclusion is more difficult, but the principle of timing is the same. In young children with maxillary deficiency, we can use rapid maxillary expansion combined with a face mask to protract the maxilla. The window is 7 to 9 years old before the sutures fuse. After puberty, skeletal response is minimal. Case correlation. A 9-year-old boy with flat midface and negative overjet. Treated with rapid maxillary expansion and face mask. Result: positive overjet, improved aesthetics. A 16-year-old with the same condition. Face mask attempted. Skeletal effect minimal, relapse high, surgery inevitable. Analogy: Class 2 is about catching the train. Class 3 is about boarding before the doors close. Pearl, face mask therapy works because sutures are plastic in children. Once the sutures fuse, biology closes the door. Section 5. Cervical Vertebral Maturation Method. How do we know when to act? The cervical vertebral maturation method is our biological calendar. On a lateral cephalometric radiograph, we analyze the second, third, and fourth cervical vertebrae. Stage 1 and Stage 2. Prepubertal. Best for expansion and early interceptive care. Stage 3. Peak pubertal growth. Ideal for Class 2 functional appliances. Stage 4, Stage 5, Stage 6, growth tapering or complete. Skeletal potential limited. Pearl. The cervical vertebral maturation method is not just staging, it is a timetable. If you can read it, you know when to push and when to wait. Section 6. Optimization. Optimization is one of the most important modern philosophies in orthodontics. Old orthodontics lists problems, fix them all. Modern orthodontics lists problems and list positives. Protect what is already good. Case correlation. Patient with severe crowding but naturally full lips and beautiful convex profile. Extraction approach, textbook occlusion, but flat profile, aged face. Alternative approach. expansion and interproximal reduction, occlusion corrected, aesthetics preserved. Lesson: orthodontics is not just correction. It is preservation plus correction. Section 7. Clinical pearls. Here are pearls you can use immediately. Premature loss of deciduous canines often leads to midline shift. Extract the contralateral canine to maintain balance. Rapid maxillary expansion before puberty creates skeletal change. After puberty, it mostly tips teeth. Face mask therapy requires 12 to 14 hours per day. Less is ineffective. Twin block functional appliances require full-time wear. Partial compliance equals minimal result. Case story: a 10-year-old boy with anterior crossbite. Rapid maxillary expansion plus face mask worn 14 hours daily. Stable correction. A 15-year-old boy with the same crossbite. Same treatment attempted. Relapse, poor stability, surgery required. Pearl: timing is the invisible architect behind every success or failure. Conclusion. To conclude, orthodontics is not simply about tooth movement. Orthodontics is the science of managing time in biology. Light forces respect biology. Early intervention prevents later disaster. Class 2 must ride the pubertal wave. Class 3 must be intercepted before sutures close. The cervical vertebral maturation method is your compass. Optimization protects natural beauty while correcting problems. Numbers guide us. Records direct us. But the face is the final judge. As future orthodontists, you are not just engineers of teeth. You are architects of faces, guardians of growth, and managers of time itself. That is, orthodontics at the professor level.